So our first session is going to be, as I mentioned, on radioligand in the, well, it says in metastatic hormone sensitive. Actually, we're going to talk about it broadly, just radioligand therapy in general. This is our panel. Why don't we start at the end, Chris? I'll have you introduce yourself and then come towards me.
Chris Sweeney at University of Adelaide.
Michael Morris, I'm a medical oncologist at Memorial Sloan Kettering Cancer Center.
Rena McKay, I'm a medical oncologist at UCSD.
Your microphone.
Is it working? There we go. Okay. Rena McKay, I'm at UCSD, CU medical oncologist.
All right. Thank you all for being here. We appreciate you. All right. Our first slide is on PSMA addition. We just heard these data at ESMO a few weeks ago. This is a composite slide. Upper left, we're looking at the schema. So this is hormone-sensitive state, at least one gallium PSMA PET positive lesion appropriate for ADT ARPI, which was the control arm in this study, and then adding 6 cycles of lutetium to this with an RPFS endpoint, crossover allowed, and then looking also at OS. Go to the bottom left and looking at RPFS advantage, hazard ratio 0.72 for the triplet arm. These data are early. There's an OS hazard ratio of 0.84, not significant yet, but an early look. You see those curves largely overlapping, some separation at the end, but a whole lot of censoring as you get towards the tail of those curves. And then the other, I think, very important piece to these data is the toxicity. So this is just part of what was presented. You see a whole lot more dry mouth because PSMA is expressed in the salivary glands. You see cytopenias. Again, this is radiation delivery, et cetera, but an important piece of this. So I'm going to ask each of you, and Rain, I'll start with you, just to give me your sort of high level. When you saw this, what did you think? Love it, hate it, in between, et cetera?
So happy to start. I'd probably say in between. When we saw the data, this is a positive trial. It met its primary endpoint, demonstrating improvements in radiographic progression-free survival with the hazard ratio of 0.72. I think when we talk about the mHSPC setting, the bar is higher than I think in other scenarios. I think it's really important to think about how patients are going to experience their time in the mHSPC setting, what's going to be the impact on overall survival, what's going to be the effect with regards to their ability to receive additional life-prolonging therapies. I think it's still early, and I think we need to see the data mature and see if this hazard ratio is actually going to translate into a statistically significant OS benefit. What's going to be the toxicity evolution over time? I think these are really critical questions to dissect. We're going to get into it with regards to what's the appropriate way to dose. This was given Q6 weeks for a total of 6 cycles. The PSA response rates were dramatic. What is cycle 3, 4, 5 doing if you have an undetectable PSA? So there's a lot of questions, I think. But this is a positive trial. I think it met its primary endpoint. I'm optimistic about what additional maturity of this data is going to show, but still lots of questions.
I'm going to ask you a quick follow-up question. I actually meant to show this second slide also just on secondary endpoints. The formatting got a little off, but about a 15% delta improvement in the RECIST response. Big improvement in PSA progression for what it's worth. The right-hand side, symptomatic skeletal event, mCRPC, and PFS per investigator. So all I think supportive of the primary endpoint, but just to show those. Rena, back to you real quick. So let's say, and I know the next session we're going to talk about the hormone-sensitive state and all the options, but let's put that aside, take these data in a vacuum. It's available tomorrow, and an appropriate patient walks in. Are you giving it, or are you saying, I want to wait for OS, et cetera? Where are you on that?
Well, I think this study was designed for an all-comer population, and I don't necessarily know that this is like an all-comer therapy. I think we need to kind of think about what is the right patient that's going to be appropriate to receive lutetium, and are they going to actually receive all 6 doses? I think we are seeing data emerge that, Michael has led from PSMA Vision and PSMA-4 on, PSMA uptake, SUV uptake being incredibly potentially prognostic and potentially predictive in this context. Like, could you actually identify the patient population that's really going to reap the most benefit from therapy?
So I hear sort of a 5 out of 10 enthusiasm.
I'm optimistic. There's going to be,
I'm very quantitative. I need a number.
Sure, you can put me at, you can put me at, yeah, actually, I'll put at 6, because I'm not just at the middle. I'm a little bit more
Noted.
than that.
All right, Michael, what do you think?
Well, I totally agree with Raina. It is very, very, very early to be.
What was the median follow-up? I'm sorry, I should know. I don't remember. 2 years?
Yes, but also think that the information fraction for OS is less than half the events, right? So I think it's very early to be interpreting the data. This is, as Raina said, a promising signal for a relatively unselected patient population. A lot of the trials that we talk about in metastatic HSPC now are selected on genomic or other biologic criteria. This is just PSMA positivity, and very few patients actually didn't screen fail this. I'd also point out, in terms of waiting for OS, this allows a crossover. And if it's like PSMA4, I mean, there haven't been that many events here, but if it is like PSMA4, then most people will end up receiving the drug on either arm. So the expectation that you're going to have this massive OS readout, I think you're going to have to wait a long time, and it's going to be a lot more subtle. And I think much like PSMA4, you may not see a huge separation of the OS curves when all of the OS data are in there. I'd also like to point out that from a tox standpoint, we need to distinguish AE events from quality of life. If I walk around with a platelet count of 90, that's an adverse event, but I'm feeling just fine. Right. So I think that the tox table is somewhat informative, and if you look at that tox table really carefully, you will see that it looks awfully like another drug that we have previously given, that Chris, sitting to my right here, has also given and led and charted. That's an anemia, grade 3 anemia rate of 5%, neutropenia 3.7%, thrombocytopenia of 1.8%. You know, we accepted that as a community in docetaxel very readily. In fact, I think when Chris presented charted, everybody stood up in the audience at ASCO and clapped. So, I think that we have to be realistic in terms of what we think in terms of AE events. The quality of life on the two arms was not statistically different. So if we do get an OS readout and acceptable toxicity to the community and an RPFS readout, I think we're there, but it's too early to tell.
We have more QOL data and slides sort of coming later. One quick follow-up for you, and then Chris, I'll go to you, is the entry criteria for PSMA PET positivity was different than Envision and PSMA4, am I right? Or no?
No, it was the same.
It was the same, okay. All right, Chris, what do you think?
I'll be the curmudgeon. Underwhelming, disappointed, and not surprised. I think we're all on that wavelength. Underwhelming, it's not a big difference.
No, I'm not on that wavelength.
Yeah.
Sorry?
Yeah, I'm on the better part of 5.
I had them at 6, maybe even 7. Michael was higher than I
I
thought.
might be less than 5.
Okay.
So people were talking about this study before it read out. What is the PSMA uptake when they are 2-3 months into their hormones, 6 months into the hormones, and they're getting dose 4 and 5? So it's not a directed PSMA therapy. It was a study to get as much drug into as many patients as possible. And disappointing when you look at the quality of life. Yes, Michael says it's not statistically significant, but red is above the green in that study. Red,
So are you disappointed more in the efficacy? You thought the signal would be stronger, or that the cost of toxicity is too high, or both? I guess?
all of the above.
All of the above.
And let's also realize this study did not compare with the other non-AR targeted therapy, the old dog. The old dog will docetaxel.
Right, so these patients were not allowed. Nobody got chemo in this.
No, they did get radiation to their bone mets or their prostate. They weren't allowed docetaxel running into it. So it's disappointing. The signal was not stronger this far into the study. Disappointing. I wanted to get away from docetaxel.
Are you sure?
Yes. People came to me and said, we're happy. No. I was very unhappy that we're still with this non-specific effective therapy with some toxicity. And the toxicity with docetaxel, the quality of life is actually better in patients with poor risk disease than here. We see the toxicity in terms of quality of life looks worse, potentially. And if you did an area under the curve, it would be positive for that p-value of less than 0.05. But that speaks to, but it's interesting, the toxicity.
I don't think anybody would say that the toxicity of radioligand therapy is the same, from a quality of life standpoint, is the same as docetaxel.
No, I would agree with you. But then you look at the quality of life data, and then it says, okay,
Across trials.
yeah, cross trials, but no, but just looking at it,
Well, in therapy,
radioligand therapy is a radiation, and it's the gift they keep on giving on toxicity. And it's interesting that the radiation toxicity looks worse after the therapy is given. And with docetaxel, the quality of life looks better after the docetaxel is given.
The kinetics of the quality of life are a little distinct from docetaxel. I agree with you. When people are getting docetaxel, their QOL, if you look at the QOL curves, they kind of decline and then they kind of get back up to kind of baseline.
Yeah, I'll differ that. If you look at, yes, that's the Stampede study where they compare it with Abretto. But if you look at the patients who have a baseline symptom burden in high volume disease, the quality of life looks better on therapy because you're getting greater cancer control and symptom control, and then gets better off therapy.
Right.
We don't have that from this trial.
No,
we haven't.
no,
We
yeah,
haven't
yeah.
looked at symptomatic versus non-symptomatic.
No. But we why aren't we doing this? Because this is not a cooperative group study where you look.
So I pause there. This trial started as a cooperative group study led by Scott Tagawa and Michael Morris. It was initially designed within the co-ops, actually went to AFT, and then because it was such a well-designed study, and the impact was high, it actually became a Novartis study. So this trial started in the cooperative group. It actually had a primary endpoint of overall survival when it was initially designed, and then that was shifted. And I'm sure Michael can speak more to that.
And I speak to also, and Chris and I are great friends, but his facile cynicism that we were just trying to get as much drug into as many people. We used that regimen because that was the only regimen that we knew prolonged life with radiopharmaceuticals. So we just moved it from the advanced setting into the near setting. Now, Chris's point about was that overdosing and did the dosimetry work out, we probably would have designed that trial differently had we had the benefit of knowing the dosimetry studies that went along with especially vision in terms of administration of radiation therapy to tumor. But that's what we had, so that's what we used. And in terms of looking at these data, as Chris has done, and said, well, I don't like this, it's like a baby is born, you look at it just after birth, and you decide, that's an ugly baby, right? You haven't given it a chance to mature.
That is not
see
true.
the data.
So no. This is only slide one.
So can I just say that there are a number of us who chose not to open the study at their site because of the design.
Well, no study is
before.
perfect, right? And this study must have been designed many years ago,
I
right?
have to say that I don't agree with you, Chris, that the control arm should be triplet therapy.
I'm not saying it should be, but it should not be. It should not be.
The standard of care when we designed this trial was an ARPI because we as a community for doublet therapy had moved on from your study with Charted, and we're now giving ARPIs and not docetaxel as doublet therapy. So that's what we use.
It's the standard therapy for patients with high volume disease or prognostic disease.
So we're going to move on. I took some of this from Arun Azad's ESMO discussion on the top right graphic, that this was based on baseline PSMA positive burden. You could say the same thing about a PSMA positive tumor burden decreasing over time, that the proportion of radiation delivered to tumor versus normal shifts over time or is different in different patients. That's how I took it. I'd love all of your
This whole
interpretation.
tumor sync strategy that was kind of, I don't know that, I'd love to hear Michael's take on it.
So let me just finish describing the slide, and then I'm going to ask you each to comment. So again, tox, the tumor sync, and is there different radiation delivery in different patients and at different time points? This is the fact P that we talked about in the curves being different, at least as one of the measures. And then on the bottom right is the upfront PSMA, which just gave 2 doses of lutetium. Chris, you'll be happy to know, with docetaxel. And I only put it up there not to talk about the data, but just to say that there are, and we're going to talk about this more as we go through, there are alternative dosing strategies that could be considered. That's the only point of that. Mike, I'll start with you.
Yeah, so this discussion, first of all, what I would say is one of all of the trials that one could have done, but one didn't actually do. And if Arun wants to show that point, I would encourage him to actually do the trial. But this is what the trial that we actually did. And certainly we can take a look at the relationship between disease burden and tox. And I think that that actually has been informative in a number of drugs with different mechanisms of action to look at, do patients with lower burdens of disease have different side effect rates? We've done that with docetaxel, for example. Not every rabbit needs to be killed with a howitzer, right? So you don't necessarily need toxic therapy for lightweight disease. We can retrospectively, and are planning to, look at the burden of disease and the toxicity profile of the drug as well as the efficacy profile. But until this is proven in a prospective way, then I think it makes intellectual sense, certainly. And the dosimetry to the normal organs is certainly disproportionately high in someone with low volume disease. So you would expect the side effect profile to be higher. But let's see.
Let me ask a practical question. I know we talked about this when we did this a year or two ago. Rain, I remember you on that panel, and Tanya and others. Yeah. If you're giving this, let's say you're giving this in practice in exactly this setting and it's set out to be 6 doses, are you repeating a PSMA PET during therapy, and are you doing anything with that information? Raina?
Yeah, very good question. I think we track PSA very closely. Actually, something that we do in our clinic is a post-treatment SPECT to actually bring patients in for a SPECT scan. It's very cheap, very easy, and you can actually see where the treatment is going on SPECT. And so, yes, you can integrate PSMA PET, but I think there's a lot to be learned from the SPECT and what's happening with PSA kinetics. The PSA...
Describe that spec. What's involved? I'm not sure I know. What's involved? Are you doing it after every dose, or what's...
It's done after every dose. It's basically like a planar scan. You don't get any, the therapeutic is the diagnostic. So you're essentially imaging where your lutetium is going within the body.
Okay.
And
how long after you give the injection do you do the imaging?
About 24 hours.
So they come back for the next day.
They come back the next day and do it, and you can actually see where treatment is going. And I think that there's things that can be learned from that. Like the PSA response rate in the control arm is so high in the context of the study at 1 year. 75% have an undetectable PSA at 1 year. If you look at the 6-month data versus the 12-month data, it's usually about a 10% increment. So if you track it back to 6 months, like at 6 months, these people are going to be at like 65%. Like, this is just my math. So they already have an undetectable PSA. We don't know what their SPECT shows. So this kind of gets into the, when the trial was designed, we didn't necessarily have all the data around adaptive dosing from therapy and sort of integrating these various things. We just were giving therapy every 6 weeks. So I think there's going to be things that we're going to need to learn about how do we optimize the dosing.
Yeah, I'm trying to think about this. There's things to learn investigatively, but in practice, that's because we're going to have a long time before those questions are, certainly answered. Michael, I want to move to you gave me the next 2 slides, and I'm going to let you describe. It's kind of what we've been talking about, but if you would just help me out and describe this, and I'll show the next one, which is that table as well.
Sure. So most medical oncologists are used to the thought that if you give a drug, especially an IV drug, but a PO drug as well, then basically the concentration in blood is the same regardless of the tumor dimensions. And so whether the tumor is big or small, I'm not talking about necessarily intratumoral vascular supply, but the drug that is delivered to the tumor remains the same even as the tumor shrinks. But that is not the same as radioligand therapy, because with a reduced tumor mass and with fewer PSMA binding sites, you also have fewer opportunities for the drug to bind to the drug, which means that there's actually less radiation delivered to the cancer as the patient responds. So this point was demonstrated very nicely and quantitatively as a subset of the VISION trial, where it was clear that within the first 2 doses of receiving therapy, that was actually more radiation that was delivered to the tumor than the remaining 4 doses that was given. So by virtue of that, and I think that Chris was alluding to this before, if you had to think about how to design trials now, especially if you're giving hormonal therapy and you see the tumors reducing in size really quickly, you might front load your radioligand therapy and actually back off the doses that follow that because there's just less disease and there are less PSMA, fewer PSMA binding sites. So you're actually delivering less radiation therapy to the tumor as it shrinks.
So this table shows in the red boxes are the median
medians.
doses, and we see numbers that obviously go down as you go over time. Is there a number? What number do you want? I guess I'm getting at. Is it when it gets down below 2? Do you say, well, then that proportion isn't favorable? If you know the question, I'm not sure why this is advancing.
Yeah, I think I'm not sure it's a question of a threshold number, but I think what that you would do is you would actually give more drug up front and then not give drug
Yeah.
on the tail end of the regimen. And so that way and in fact, if you look at the Stampede 2, which includes lutetium, there is a modified dosing schedule in order to sort of front load the lutetium as opposed to giving all that extra drug at the end. And the one thing I would say about both Chris's criticism and Arun's criticism is that you don't know these things until some time has passed. We started designing this trial in Alliance, probably got to be about 10 years ago.
Yeah.
So it's great to stand on the sidelines and criticize other people's work, especially with the retrospection of knowing what you know now and implying, well, a decade ago, you should be as wise as you are now. And it may well be that, the next trial will not test that. But this is the only phase 3 trial in this space with lutetium. So this is what we have. And I would say, sure, we would do it differently now.
Yeah, of course.
I'd be the first to say that.
So I think the slide's on a timer. That's why it's going forward. So I'm just going to go forward. And so, Chris, maybe now I'll ask you to comment on this. So Kimchi presented this PR21 data from the Canadian Cooperative Group. This is CRPC right now. So now I think the rest of our slides sort of jump around a little bit and go to include CRPC. So you can see the eligibility there, PEP positive, et cetera. So a typical MCRPC population, standard docetaxel, we call it standard lutetium with crossover at progression, et cetera. On the left is RPFS, which doesn't look different. Identical hazard ratio 1.01, medians in the 9 to 10 month range. There was a difference in OS for what it's worth. Hazard, favoring the docetaxel first arm. You see in that small sort of bullet on the bottom right there about the crossover was not the same. So 38% crossed over to chemo and 57% to lutetium. So when you're interpreting the survival signal. So Chris, I don't know if you saw these data at ESMO. How would you interpret that? We've been talking about chemo and lutetium and where to integrate. And I think, to me, this is one of the first studies to sort of look at that sequencing. I know there have been some others, but what do you think?
Yeah, vote Eurasia. That's one of the conversations we had in the tweeting thing. We need more points, 13-0, but still counting, versus America. So this speaks to one of the questions. So I'll go back and say, we need to be cleverer, more smart in our trial design. And we need to be braver in our therapy questions. This was brave. This was a cooperative group, which was asking the question, can we possibly not be as good as our standard therapy and go against docetaxel? That's the value of a cooperative group. So the FDA has now said, we've got so many studies now going on, so we're not comparing against the right therapy. We aren't using the right dose. So yes, when PSMA addition was started, it went racing to a car accident by not having the right dose and the right schedule, because let's get as much drug into as many patients as possible. Now Project Optimus with the FDA says, let's get the right dose, let's get the right schedule. And we can do this time and again. Paclitaxel started at 225, we use 175. Cabazitaxel started at 25, we used 20. And docetaxel started at 75, 100, we come to 75. Enzalutamide started at 160. Some patients don't need that. We need to be better in our trial design, and we need to be more brave in our comparison arms.
In fairness to the Alliance group, that all happened afterward, right? Your initial step is you take the information you have with the dosing isn't
Yes.
perfect. You see if there's a signal. If there is no signal in PSMA addition, well, then you're done, right?
Yeah,
If there's
no,
a signal,
yeah,
then you
I'm
can
not-
say,
I'm
let's
not-
talk
I'm
about
not-
dosing, etc.
I'm just saying we need to be, let's learn from that.
We
Let's
all
be
agree.
smarter going forward. Some of us were questioning the design and the dosing schedule from the beginning. The FDA said, get smarter in your dosing. And let's just be honest and real. Dosing in trials of give as much drug to as many patients to make as much money as possible. And let's be smarter. And
Well, I don't
try-
think the Alliance was thinking about that when they designed the trial. I think I
No,
can
no,
speak
no,
for
but-
Michael.
but-
Well, let's move to this slide. We're off
Novartis took
PSMA
over.
addition.
Novartis took over.
We're
I'm
off
just saying,
PSMA addition.
let's be
We
let's
agree.
be honest.
We agree we should be smarter. PR21, do you think this helps us sequencing? Now we're in the CRPC state. Is it useful? Is it interesting? Would you use this in practice? That's my question.
This is saying you're giving a non-targeted therapy which benefits most patients. If you gave this to patients who had PSMA SUV mean greater than 10, the 30%, that would probably be the switch on that OS curve.
Michael, what do you think?
I think it's a really interesting study, and I like it a lot. I think that I'm confused why RPFS was the same, but OS was better in the sequence of dosi followed by lutetium. But I think from a practical standpoint, this trial speaks to the real sequencing question that we have. And I'd love to see this concept expanded so that we have the numbers to really do these comparisons. But if there is a difference in outcome in terms of survival by the sequencing, then by all means, let's follow that signal and explore it further.
Reina.
I actually really like this trial. And I think what this trial shows us is that both lutetium-617 and docetaxel are actually highly effective treatments. It also kind of highlights our vulnerabilities in the MCRPC setting when we undertreat patients, because I think the issue with the control arm is most of the patients who started with docetaxel, a lot of them went on to get lutetium, whereas those patients who started with lutetium didn't necessarily go on to get another life-prolonging therapy. I think there's going to continue to be a colored signal in OS. We chatted about this earlier. MCRPC is a grossly undertreated disease across the US and across the globe. There are many life-prolonging therapies, and when we give them to patients, they live longer. I think that's what we're seeing in the OS data, in that, when they got lutetium, they were like, I'm not getting chemo, but when they got chemo, they're like, I still want my lutetium.
Do you think is that a tolerability issue? Like it's easier to get one after the other versus reverse, or something else? I'm not sure.
I think we need to dissect it.
We don't know.
Like, why? Like, is it a
There's a 20%
side effect
difference,
thing?
yeah.
Is it what was the reason?
And I don't
of the
think we got
lutetium?
that data at ESMO. I don't think we got any insight into that. Okay. Did you want to say something? I was going to
Yeah, I think that's the importance of collecting real-world data in the post-Pluvicto world.
Yeah.
And we have such a paucity of of information of what those patients are receiving. I think that there now for CRPC, probably more patients getting, or will be more patients getting Pluvicto up front than Dosi, whether that's right or not. But we have very little idea of what actually, both from a tolerability and just a practice standpoint, those patients look like and what treatments that they're receiving.
So we're quickly running out of time, unfortunately, but I want to broaden these are all just the Kaplan-Meier's RPFS on the left, OS on the right for the 3 trials, Vision, PSMA4 in addition. So all the big trials that I'm aware of. And I just, sometimes it's helpful to put all these on one screen and say, what is the shape of the curve and when do they separate? And I'm just sort of wondering, like, what learnings would you take from it? Or you'd say, well, it's all separate and I can't really take anything. Reina?
PSMA addition was a wonderful study. It was a modern day study, and it had a control arm in an unselected population in the mHSPC setting of an ADT and an RP. That's a very high bar. So I think what we're seeing is when we look at PSMA4, where we're comparing to alternate RP, when we look at Vision, where we're comparing to best supportive care, a lot of alternate RP, maybe some steroids, maybe some SBRT, but PSMA addition was a highly effective control arm. So I think we're, seeing that.
So you think this is mostly a control arm effect?
Well, I think lutetium is a highly effective treatment. And I think the effect size, I do think is somewhat driven by the space and the performance of the control.
Michael, anything to add?
Sure. I think what you're seeing here in terms of the OS also is the building in of the crossover, which may make OS harder for the academic community to read, but I think from a patient perspective was the friendliest, most ethical way to do those trials. I also think in terms of PSMA addition, remember all triplet therapy that we currently use is using a trial design that speaks nothing to contemporary practice. Those trials were ADC-DOSI plus or minus an ARPI. PSMA addition was ADT ARPI plus or minus lutetium. So in terms of interpreting this data is actually based on current practice, not some previous world's practice that we now contemporarily make decisions on triplet therapy for.
Fair enough. Chris, anything to add? Big picture
So
on
there's
these
a study
curves?
missing here called Therapy, which compared lutetium against cabazitaxel, post-docetaxel in CRPC.
Randomized phase 2.
Randomized phase 2, but that would have been a
can only
futility
fit so
study.
many-
They would have shut down.
I
They
only
would have
fit so
shut
many
down the
curves.
study, and they said, "Let's not go on," because it was basically the same. So it again speaks to, I will be that person in the room who says, "This is these are all pharmaceutically driven studies that actually are designed to try and the best to make a positive study and not go against the standards." So vision, cabazitaxel, yes, the same, equivalent, basically futility, you wouldn't have gone forward. And yes, the drug works, but we need to do better for our patients and work out who it works best for.
Thank you. All right. This is the same studies, but now looking at quality of life. Michael, you gave me this slide. So again, maybe I'll ask you to comment, Michael, what can we take from these data?
So vision was the most advanced patient population and the one with the fewest treatment options, and basically was a hat trick in terms of field function and survive, hitting on all three. So there were 2 measures of quality of life in vision, as well as the BPISF, and all of them hit. PSMA-4 also was an either-or study, unlike PSMA addition, which was an and study, right? So PSMA-4 showed that if you were a cancer patient in the pre-chemotherapy setting with metastatic CRPC, you were leading a better quality of life if you're getting lutetium than a second-line ARPI. From a QOL standpoint, again, hit on all counts. The PSMA addition, I think, is too early, but this is an and study, so it's triplet therapy. So there, I think the points that Raina was raising is when you're adding something, you're probably going to see more AEs. The question is, are you seeing a benefit on the cancer control side and on the survival side that makes that worth it? And I just feel we don't have the data right now.
Rena, anything to add?
No, I mean, I think the and versus or, I think is important to think about here and think about the context, whether you're adding a therapy versus doing an alternate. I think it's interesting when you look at the PSMA addition that really during the first 9 to 12 months, the curves are kind of overlapping, but then you start to see a little separation over time. And I think we're going to just need to see the evolution of the quality of life over time and the evolution of the AE profile over time to understand that delta. There's no statistically significant difference in QOL and PSMA addition, but what does
But the
that mean?
curves are separate.
Yeah.
Chris, do you think the current quality of life questionnaires, the pain questionnaires, do they adequately capture what we want to capture in prostate cancer?
No. And the ones we choose in the domains we choose to present are the ones we want to present. There's so much granularity. The quality of life with enzalutamide and enzamet, overall, no difference. We know that's crap. Some patients have side effects above ADT, and when you look at it, fatigue and quality of life is worse. When you look at that one domain, we need to be more thorough, more detailed, and more patient-centric in our designs and in our analysis.
I think that's true across every disease. Okay, I'm going to show one poll that we put out on Twitter, and then I'm going to ask each of you, and we're going to wrap the session with this. You're going to comment what you think of this, And then I had some slides on future, but we just ran out of time. So it'll then give me your one statement about what is the most pressing question of radioligand in prostate cancer. So Rain, I'll let you go first. So what do you think of the poll quickly? And then what's the most pressing question?
You know, I have to say I'm not really clear on the question. In which prostate cancer disease state do you think so where would I use lutetium the
Yeah,
most?
where do you
basically?
think the benefit risk is optimized?
Right now in the CRPC setting, and I don't think we need to anchor lutetium to chemotherapy receipt.
So one of the top two, you don't really care about the timing of
Yeah,
chemo.
I don't think it needs to be anchored to that.
Fair enough. And then what do you think the one question that if you were in charge, had all the money and resources, I want to answer this question?
Around lutetium?
Yeah. Around radioligands, but it's lutetium.
Oh gosh, there's so many questions.
Yeah, only one. You only get one.
I know. Oh,
We can come back
man.
to you if you want to think.
Schedule in the mHSPC setting, I think, is going to be a big one.
So scheduling number of doses. Michael?
I'm not sure I'm pegged to a pre-chemo, post-chemo. That's really a regulatory framework as opposed to a biologic one. But I do think I myself vote with my feet and generally give it a pre-chemo in today's day and age. And that's in discussion with my patients as well as to what they want. Most pressing question for me is given the fact that radioligand therapy really is only inducing responses about half the patients, which is true for most of our therapies that are successful. It's either 50% or below. The most pressing question to me is what combinations should we be entertaining in order to really optimize the global tumor control that we can exert with at least a backbone of radioligand therapy or some other therapy that radioligand therapy is supporting so we can get that response rate to greater than 50%.
Thank you. All right, Chris?
What amount of PSMA PET qualifies a patient to benefit from lutetium PSMA? That's the question we need to get answered as quickly. It's a targeted therapy, giving a radioligand to a target. What amount of PSMA PET do you need? That's the question I think we need to answer. It's a target therapy with a target. Docetaxel, terrible drug in terms of non-specificity, but it works, but we don't have a target. We have a target with lutetium PSMA. Let's find out what dose, what schedule, as quickly as possible in the single agent setting.
I thank you all for your lively discussion first thing in the morning.